So patients with memory loss can get appropriate diagnosis. And no matter where you practice, your population is at risk for dementia, and thus your practice is at risk for a lot of scans for memory loss. But don't fear. I'm going to show you how to look at a scan with memory loss and remember what is important so that you'll never forget it. I have no disclosures other than I absolutely, wholeheartedly love and support the mission of Radiopedia to bring radiology education to all, and I am so honored to play just a small part in that today. Now, dementia is actually kind of an umbrella term. It encompasses, a vast array of very, very different pathologies that all have the end result in resulting in advanced cognitive decline for age. So when we are looking at a scan for dementia, essentially what the clinician is telling us is, I clinically see advanced cognitive decline for age, and there are numerous possibilities. Now, what can you tell me about what might be causing it in my patient? Now, while they might love for us to give them an exact answer, oftentimes we can't. And they know that. So instead, what they're looking for is for us to answer a very important question for them. Is there some action that they can take to help this patient with cognitive decline? So the way I kind of think of it is I think evaluating a patient with memory loss on imaging is kind of like evaluating problems in a relationship. There are really two types of problems in a relationship. One, the problems that you can fix, right? Like you guys don't communicate well. You can work on that. You can fix that. And it's the same for dementia. There are treatable pathologies that can underlie, dementia. Subdural hematomas can cause dementia for Mass Effect. Tumors like a big frontal meningioma can cause dementia. And of course, there's normal pressure hydrocephalus. And so these are pathologies where action can actually help resolve the cognitive decline or at least make them, significantly better. You can evacuate the subdural, you can resect the tumor, you can shunt the hydrocephalus. But then there's the other type of problem in a relationship, and those are the ones that you cannot fix. If he's got a wandering eye, he's always going to have it. It's always going to cause you problems, and honestly, you should probably find someone else. So it's the same with dementia. There are dementias that you cannot reverse. And this is what we commonly think of when we think of, neurodegenerative diseases like Alzheimer's disease, or Lewy body, or CJD. But even among those dementias that you cannot reverse, there are some things that you can do to slow the progression. So I kind of think of these irreversible dementias like jumping off a cliff, right? Once you've jumped, you cannot go back. There's no going up once you're falling. But you can do something to, soften the blow at the end. So it's kind of the same with these, dementias that aren't per se reversible, but there are some where you can give treatments that will slow the progression, kind of the same way you can cushion the blow from a fall. And the two big dementias that we do have interventions to slow the progression are vascular dementia and Alzheimer's disease. So for vascular dementia, the treatment is to treat the underlying cardiovascular disease. So that means, really tightly controlling blood pressure, working to reduce cholesterol, treating any underlying diabetes or atrial fibrillation. The goal is to stop future vascular insults to slow any progression of the dementia. Okay, so it seems pretty obvious how, we can stop the progression of a vascular dementia. But how do we stop progression of dementia in a much more complex disease like Alzheimer's dementia? So to understand how we can try to slow the progression of Alzheimer's, you have to understand the pathophysiology. So the current hypothesis in Alzheimer's disease is that it comes from accumulation of amyloid beta protein. And this accumulation results in inflammation, and this results in neuronal toxicity and neuronal death. And this neuronal death from the inflammation from amyloid beta protein is what causes the cognitive decline. So the current new treatments in Alzheimer's are focused on anti-amyloid beta antibodies that can help remove this protein from Alzheimer's patients and hopefully slow the progression of disease. Now, the important point is these work best the earlier they are given in the course of disease. Because if you give it late, well, if the neuronal death has already taken place because there's already been a lot of inflammation, removing the amyloid beta and stopping the inflammation doesn't have as great an effect. So that's why it's becoming increasingly more important for us to be able to diagnose Alzheimer's early and diagnose it accurately so that these treatments can be started as soon as possible in the disease course. So when it comes to dementia, it's important to remember that imaging is just one piece of a very large puzzle. It's important to remember that we're not the last word, Instead, our imaging findings should be taken in the context of kind of the greater workup for dementia. That includes lab tests, CSF testing, or cognitive testing, sometimes, even EEG. But that being said, we as imagers are a very important piece of that puzzle. And so it's important that you know what to look for on these scans. So let's start with the first question. Is it, a reversible cause of dementia? Now, you probably know how to diagnose a subdural hematoma or a tumor. You don't need my help with that. So instead, I'm going to concentrate on the possible, more tricky cause of possible reversible dementia, and that's normal pressure hydrocephalus. Normal pressure hydrocephalus is one of the most difficult diagnoses in dementia imaging because obviously you do not want to miss a reversible cause of dementia. But at the same time, many people have large ventricles related to volume loss, so you don't want to be overcalling it either. So how do you make sure you're not undercalling or overcalling? So there is an NPH-RAD scale, which scores 7 different imaging features. And, if you get a score above 8, then, it's very likely you have NPH. But no radiologist who is in clinical practice is going to take out calipers and evaluate 7 different imaging findings on every dementia MRI. And also, it actually doesn't help predict who's going to respond to shunting. So if you know me, I hate measurements. Because measurements, they're not just burdensome. They also introduce inter-reader variability. In fact, a lot of the RAD scale measurements can change depending on your scan angle. Most of the literature is based on scans through the ACPC line, but you have no idea how your tech has scanned the patient. However, the Symphony trial for NPH actually made it much easier for us. They narrowed it down to 2 imaging size criteria. Now, the first is that there's an Evans index greater than 0.3. So the Evans index is the ratio of the maximal frontal horn diameter to the maximal cranial vault diameter. And a ratio of more than 0.3 means that there's hydrocephalus. Doesn't mean necessarily NPH, but there is hydrocephalus of some kind that is present. Now, I think an Evans index of greater than 0.3 means the ventricles look like the giant eyes in the mask of that killer in the Scream movies. So basically, if I see ventricles that are so big that they look like horror mask movie eyes, then I call hydrocephalus. I look for that ghost mask on all of these MRIs. So if an Evans index of more than 0.3 means hydrocephalus, well, that helps us somewhat, but how do we know if the hydrocephalus is normal pressure hydrocephalus? So for this, the Symphony trial used the finding of tight medial CSF spaces at the vertex, but wide sylvian fissures. Some call this disproportionately enlarged subarachnoid spaces, or DESH. And this type of DESH, where there's tight spaces superiorly and wide sylvian fissures, is best seen on the coronal images. Now, I think that this finding of having tight CSF spaces at the vertex and wide sylvian fissures makes the brain on the coronal images look like a chipmunk. The widened sylvian fissures separate the temporal lobes from the rest of the brain. And this makes them kind of like chipmunk cheeks, and then kind of the tight CSF faces at the vertex. I think that looks like the little chipmunk tuft of hair at the top. So this separation of the temporal lobes, these chipmunk cheeks, are not seen when the ventricles are big related to volume loss. Because when it's volume loss, the sylvian fissures are being closed. So it'll look more like a mushroom rather than a chipmunk cheek.
Chipmunk.
Because this chipmunk cheeks, this separation of the temporal lobes and wide sylvian fissures isn't seen with volume loss, it actually is quite specific for MPH. If you see these scream horror mask and chipmunk cheeks, that means there's a 70 to 80% chance that that patient will respond to shunting, which is actually the basic MPH response rate itself. So, whenever you're looking at a study and trying to figure out if it's MPH, don't break out your calipers. Look for the scream mask and chipmunk cheeks, and you won't have to swirl around when you're looking for MPH again. So the next question we ask is, if it's not, one of these reversible causes of dementia, is it a cause that we could possibly, intervene upon to slow the progression? And for this, the two main causes are vascular dementia and Alzheimer's dementia. We will start with vascular dementia. Okay, vascular dementia, or what's more technically called vascular cognitive impairment. Now, almost everyone worked up for dementia has infarcts. So how do you know which ones are the important ones? Vascular dementia used to be called multi-infarct dementia. And this was because it was thought that dementia directly resulted from the brain volume loss from the infarcts, which, the thought that kind of the threshold for dementia was when about 50 to 100 cc's of infarcted tissue was found. And that point, they felt that it caused dementia. But that understanding is really outdated now. So we now know that really vascular dementia results from really many diverse pathologies that all share a common vascular origin. So it's possible to just lose a little volume from infarct and still have dementia if you lose volume in the right place. So if in the age group that's being worked up for dementia, you see infarcts everywhere, which are the ones that you should be paying attention to that could cause true cognitive impairment? To understand which vascular findings are key in vascular dementia, you should think of vascular results kind of like a punch to the brain, right? So every punch does some degree of damage. So every infarct does some degree of damage. But remember, not all punches are equal, right? A punch to the face is not like a punch to the hand. So not every infarct is as devastating. But again, like punches, they're cumulative. The more punches you have, the more pain you have. The more infarcts you have, the more damage that you've done. But again, not every punch is equal. So if every punch or infarct causes some degree of injury, you can think of dementia kind of like a knockout. Enough damage to overwhelm the brain so that it's taken out of the fight. So the same injuries that cause a knockout are the same ones that can cause enough damage to cause vascular dementia. So let's talk about what you need to do to knock someone out. The classic way, or the most direct way to knock someone out, is just to beat the daylights out of them, right? That's how most fights ends, right? If there's enough damage, then your opponents, they're just not going to be able to stand. And this is, kind of the idea of multi-infarct dementia. It's the thought that more damage results in more cognitive impairment. But it's not a 1-to-1 ratio like we used to think of in the old days. So volume definitely has an impact. Like if you have a ton of infarcts, it's going to cause a ton of damage. But it's not simply the number or the volume overall that's the most important thing. Think of it kind of like a machine gun shooting at a target, right? You don't have to have good aim. Eventually, you're going to hit something that's going to take the person down, right? And so the new kind of concept, the way we think about multi-infarct dementia, is not per se that the volume is everything, but that if you have enough volume, if you have enough infarcts, eventually you're going to hit something important that will cause dementia. Now, we used to think that dementia was a direct relationship with volume loss, like 1-to-1, right? You lost more volume, you have more cognitive impairment. But now we know some infarcts are more impactful than others, right? So if you have enough infarcts, you will eventually find yourself having the impactful ones. So it's not a linear relationship, but it's just if you keep on having infarcts, eventually you're going to hit important things, and that's what's going to cause the increase in cognitive impairment. So the overall severity does matter, but it matters because you're just more likely, the more infarcts you have, the more likely you are to hit something important. So what's another way to take someone down? Well, the chokehold, right? Hypoperfusion. So signs of hypoperfusion on imaging are infarcts that are in the border zone or watershed distributions. And this is typically because there's a chronic large vessel, either ICA or MCA stenosis, or even an occlusion. But it's not just these watershed infarcts that cause the dementia. They're kind of like a macroscopic sign of the underlying microscopic disease. If there is hypoperfusion, there isn't just macroscopic hypoperfusion, but also chronic neuronal hyperperfusion on a neuronal cellular level that causes damage and dysfunction and dementia. So you have chronic oxygen starvation of every single neuron, not just the infarcted ones at the watershed distribution. But unfortunately, we can't see that microscopic cellular damage. We can only see the macroscopic damage, and that's border zone infarcts on imaging. So I always remember that the major vascular territories are shaped like a butterfly, and the infarcts are at the butterfly junction zones, right? Where the wings meet the body, where the tail meets the wings. And these infarcts at these border zones indicate underlying hypoperfusion. So it's the next way to take someone down. A knockout punch, one and done. So a knockout punch in vascular dementia are strategic infarcts. These are infarcts that are located in structures directly related to cognition. So damage to these structures results in dementia without really needing any other significant volume loss. Now, rather than, shooting machine gun like we were when we were using volume to eventually hit something important, this one we hit the target right on the first time like a ninja. So just one shot right to the heart, you take it down. Just one infarct in one of these important structures can cause dementia. Just like one shot to the heart can take you down. So what are these important structures that can cause dementia if they're hit? So there are many structures that have been implicated in strategic infarct dementia. The main ones are the hippocampus, the internal capsule, the thalamus, especially the paramedian region, and the caudate. So I remember the mnemonic, one hit causes dementia, to help me remember where important strategic infarcts will be located. Okay, what's the next way we can take someone down? Well, we can break their legs, break their important connection, right? Like if you break their legs, those important connections that keep them walking, they're not getting up. The same is true with infarcts. Small vessel disease, or subcortical microvascular infarcts, break important white matter connections, so different parts of the brain are no longer connected and they can't function. Now, these small vessel infarcts disrupt connections between the frontal lobe, the deep gray structures, and the parietal lobe. So they kind of result, in decreased executive function because the frontal lobe's not connected, decreased attention and memory. And so the more small vessel disease you have, the more connections that are broken and the bigger the impact. So it's always important on every single study that you read for possible dementia to comment on the degree of small vessel disease. So what's the final way to take someone down? Play dirty and make them bleed, right? We're talking about now hemorrhage or hemorrhagic infarcts. Seeing hemorrhage or remote hemorrhage on an MRI for dementia is a sign of either small vessel disease from hypertension or amyloid angiopathy. And amyloid angiopathy has an incredibly strong correlation with dementia. In fact, amyloid angiopathy has such a strong correlation with dementia that some say it should be thought of more as a neurodegenerative disorder that occasionally causes, small vessel disease and hemorrhage and strokes, but that really its day job is neurodegeneration and its side gig are the, chronic small infarcts that we see on imaging. Now, how does amyloid angiopathy cause all of these problems? So it causes both neurodegeneration and stroke because these amyloid proteins build up in the vessel wall and kind of the surrounding perivascular space. So now, in the vessel wall, it causes weakening of the vessel wall that can lead to rupture and hemorrhage, and that's why we see microhemorrhages associated with amyloid angiopathy. But in the perivascular spaces where it builds up, it causes clogging and decreased clearance of solutes. Having, solutes build up is kind of like having a clogged drain, right? If you can't drain the perivascular spaces around your vessels, it's just like your bathtub is clogged, right? And so what happens when your bathtub is clogged? Everything gets dirty and you get all this stuff sitting around that's erosive to your pipes. Same thing with the brain. All of this amyloid sitting around causes damage to the vessel so that you get hemorrhage and bleeding, and damage to the neurons so that you get neuronal death. So when you are reading any study for dementia, it's always important to mention any signs of hemorrhage or microhemorrhage that may indicate amyloid, because that not only contributes to the microhemorrhages, it also contributes to neuronal death and dementia. So now hopefully you know all the important signs to look for when you're reading a dementia study that may contribute to vascular dementia. So now you can make all the findings so you have a report that's a knockout punch. Okay, now let's get to the most common and most important cause of dementia. And it's actually one that does have a potential intervention. Of course, the literal and figurative granddaddy of them all when it comes to dementia is Alzheimer's disease. It is overwhelmingly the most common type of dementia. So one of the most important things to look for when you're looking at a scan for Alzheimer's is whether or not there is volume loss, and if there are volume loss in specific regions. So when you look at a scan for Alzheimer's, do you just kind of gestalt the volume loss and hope no one asks any more questions? Does your practice use automated software to provide the answer? Or maybe there's a better solution than both. So it's important to note that there are specific patterns of atrophy that are associated with Alzheimer's disease. So atrophy in Alzheimer's disease often involves the hippocampus and the anterior medial portion of the adjacent parahippocampal gyrus, and this specific region is called the entorhinal cortex. And so this is where we should be looking for volume loss on scans for Alzheimer's dementia. Now, many of you will kind of just gestalt the atrophy in this region. Others use these automated software that can quantitate volumes down to the hundredths of a milliliter and compare them with, a database of age-matched controls. Now, you might say, wow, clearly, going down to the hundredths of a milliliter, age-matched controls, big data, this must be better. Who wouldn't want more data? And it's because of that perception that people tend to think that, the automated, the computer method must always be better. But this just isn't always true. There can be segmentation errors in the software that affect the analysis. When you have such a small volume as the hippocampus and entorhinal cortex, even very small errors in segmentation that cause small errors in volume analysis can actually make a huge difference in the percentiles that you see. Another problem is that the automated software analysis can only be used on studies that have specific volumetric imaging. But a lot of times that's not what you have. You have CTs or just routine MRIs, and you really want to be able to give the clinician an idea of whether there may be Alzheimer's present. And here, you're kind of out of luck. Automated analysis can't help you. But at the same time, gestalting isn't great either. It can be accurate, it's not reproducible. So maybe the answer is kind of like Goldilocks, right? The automated software is, it's way too hot. And Disc is still thinking, nah, too cold. Maybe it's somewhere in between with a semi-quantitative method. A method where you do have data, but you're not using computer automated analysis. And there are two very reproducible semi-quantitative scores that exist. The medial temporal atrophy score to look at the hippocampus, and the entorhinal cortex atrophy score to look at the entorhinal cortex, also called ERICA. So, how do we use these? Well, let's start with the medial temporal atrophy score. Now, on the coronal images, I think the hippocampus looks kind of like a bird. And typically, in a healthy hippocampus, there's very little room around the bird's head. But with volume loss, the CSF kind of slithers around the head of the bird like a snake. And all the medial temporal atrophy score does is grade how far the snake has gone towards slithering around that bird. A medial temporal atrophy score of 1 is the first step that snake takes as it slithers around towards eating the bird. So here, the choroidal fissure has widened slightly. So what it looks like is that the snake has begun to kind of just slither over the head of the bird as it goes around to completely encase it like a boa constrictor. So this is just the first step where the choroidal fissure widens. For a medial temporal atrophy score of 2, the temporal horn also widens. So not just the choroidal fissure, but also the temporal horn. And when this happens, CSF can be seen encircling the entire top of the hippocampus. So now, the snake has taken the next step as it begins to encircle the bird like a boa constrictor. It hasn't just kind of crept in, it's gone all the way around the back. For a medial temporal atrophy score of 3, the hippocampus now shows moderate volume loss. When you have that volume loss in the hippocampus, it kind of looks like the head of that bird is compressed. So now, as the snake has previously already encircled the hippocampus for a medial temporal atrophy score of 2, now for a medial temporal atrophy score of 3, it begins to compress it as it begins to squeeze its prey. It's not only encircled the head, but now it's done the final steps to squeeze down as well. For a medial temporal atrophy score of 4, now you have profound hippocampal volume loss. So it looks like the bird's head is not just being squeezed, it's absolutely crushed, right? The boa constrictor is finally just crushed in the skull of its prey, and that's why the hippocampus looks so small. So when you're looking for the medial temporal atrophy score, think about where the boa constrictor is in attacking the bird. Has it just slithered in? That's a medial temporal atrophy score of 1. Has it encircled it? That's a medial temporal atrophy score of 2. Has it begun to squeeze? That's a medial temporal atrophy score of 3. And finally, if it's begun to crush the bird, that is a medial temporal atrophy score of 4. Now let's talk about the entorhinal cortex atrophy score, or ERICA score. Now, it's evaluated at the level of the mammillary bodies. And in this region, I think that the perihippocampal gyrus and the adjacent fusiform gyrus look like two shoes going up a ramp. And the entorhinal cortex is the shoe that's in front. Now, when you get entorhinal cortex atrophy, it begins to look like the feet slip, kind of like, when you're walking, you slip on a banana. So, in the most mild case, your front foot just slips a little bit and you kind of feel like, whoa, and your legs separate a little bit, but, nothing too bad happens. So the same with the entorhinal cortex. If there's just mild volume loss, the volume loss widens the collateral sulcus here, so it looks like the legs are just a little bit spread out. And this is an ERICA score of 1, just a little bit of spreading of the legs. Now, if your slip is a little bit worse, you kind of lose your balance a little bit, and your foot will actually come up off of the floor. And the same thing happens with the entorhinal cortex. If there is more pronounced volume loss, the entorhinal cortex volume is enough, so there's now not only CSF widening between it and the fusiform gyrus, but also between it and the tentorium, or the floor that it's walking on. So it looks like the foot is kind of picked up as it slips. Now finally, if you have a really bad slip, like you are going off, you're going into the splits in the air, your feet are off the ground, your legs are out wide, and this is the same way it looks when there's profound entorhinal cortex volume loss. There is so much volume loss that the collateral sulcus doesn't just look like a small gap between the two legs. It looks like the full-on splits. You're up in the air. So again, you have that entorhinal cortex lifted off of the tentorium when you have profound Erica 3 level volume loss. And it turns out that these semi-quantitative methods of looking at volume loss actually perform just as well as the automated analysis. So you should really kind of think of automated analysis like bottled water. It's more expensive, but it has its advantages, like, it comes in convenient packaging. But what really matters is being able to quench your thirst. For that, bottled water doesn't do any better than the water straight out of your tap. And this is the same thing for automated analysis. Are there advantages? Is it more convenient? Is it very fast? Yes. But for what really matters, being able to diagnose the degree of volume loss of the entorhinal cortex and the hippocampus, it doesn't perform better than what you can do on your own with these semi-quantitative scores. So for every study that you read for dementia or memory loss or even for falls, right? This is one of the great advantages of these semi-quantitative methods. They can be used on any study, even a head CT out of the ER for falls. You should ask yourself 2 questions. 1, how far has the snake, the boa constrictor, gone in his attack on the bird? And 2, how far have your shoes slipped on a banana? And that's all the analysis that you need to be able to evaluate for possible underlying Alzheimer's dementia. So now you know the framework to approach an imaging study for dementia. First, ask yourself, is there a reversible cause, such as mass effect or NPH? And if not, is there evidence of the type of dementia where we can intervene to stop the progression? So you should look for, are there findings of extensive vascular disease, signs of hypoperfusion, or strategic infarcts? And you should look for volume loss that's in a pattern suggestive of Alzheimer's disease, specifically looking at the hippocampus and entorhinal cortex. If you approach imaging for memory loss in this way, you'll never forget an important finding. Thank you very much.